Vascular access devices, considerations for the ICU nurse. There are many options available when vascular access is needed for your patient. When considering what is right for your patient, you should always select the least invasive vascular access device with the smallest outer diameter and fewest number of lumens to meet the patient's needs of the prescribed therapy. At SMCS, we also have a policy that supports the use of peripheral IVs for low to mid-range vasopressor use for less than 24 hours. There are important monitoring and assessments that must happen if you are going to infuse vasopressors through a peripheral IV, but this is a great option if central access is not available or if it is only being used for mid to low dose vasopressors, for instance, to treat transient hypotension after intubation. The assessment and documentation for vasopressor use via a peripheral IV must include an IV site assessment every hour and checking for blood return every 2 hours. Additionally, we have the option of midline catheters placed by our vascular access team. A midline catheter is a vascular access device approximately 8 to 20 centimeters in length, inserted into the veins above the antecubital fossa. The tip of the catheter remains in the axillary vein just short of the subclavian. A midline catheter is not a central access device. You should consider a midline for infusing medications and solutions such as antimicrobials, fluid replacement, and analgesics that are peripherally compatible. Do not use a midline catheter for any medication or intravenous therapy that cannot be administered peripherally. Use a midline with caution for intermittent vesicant administration due to risk of undetected extravasation. Do not use a midline for continuous vesicant therapy or TPN. Midlines may be used for lab draws as needed. In an emergent situation, all emergency medications may be administered via midline provided that the infusion is changed to a central venous access device as soon as it is clinically feasible. In the case of an occluded midline, TPA is not approved to resolve occlusions. An occluded midline will need to be replaced. So what does this all mean for you as the bedside nurse? Beginning March 8th, we will begin using the surrounding script to ensure we are addressing vascular access as a whole. The goal of the script is to not only address if the patient has a central line and if there is an indication for removal or an alternative access that could be utilized, but also to discuss the appropriate vascular access device if additional access is needed. We will also have this resource available to you on all of the WOWs to reference. The same education will be going out to physicians, so we will all be addressing vascular access in the same way.